Good morning, good afternoon, or good evening. Thank you for your interest in the IDSA Foundation's Dr. John G. Bartlett Education Series. We are pleased to offer today's program entitled PrEP, Implementation in Primary Care, Overcoming the Barriers of HIV Testing. And also wanted to make you aware of another program of a similar topic, the importance of HIV testing in the different population groups, that will air on June 27th, which is, of course, National HIV Testing Day. That program will also begin at noon Eastern. To access this or other webinars in our educational programs, please visit the IDSA Foundation's website at www.idsafoundation.org/your-health. Or please sign up for our monthly newsletter and you'll stay informed with all of our educational opportunities throughout the year. At this time, it's my great pleasure to introduce today's moderator, Dr. Rupa Patel, who will in turn introduce the rest of today's faculty. Dr. Rupa Patel is a research associate professor in the Division of Infectious Diseases at Washington University in St. Louis. She is a former director of the Midwest CDC HIV Prevention Capacity Building Center. She is a member of the Technical Advisory Group for PrEP, implementation for the World Health Organization, and strives for a future where there are zero new HIV infections. Turn it over to you, Dr. Patel.
Hello, thank you everyone. We're so excited for you to be here. I'm going to introduce our esteemed panel today before we launch into the presentations. Our first speaker will be Mr. Dr. Errol Lament Fields, MD, PhD, and MPH from Adolescent Medicine and Associate Professor of Pediatrics at Johns Hopkins University. Dr. Fields is a physician researcher and board certified in pediatrician and adolescent medicine subspecialties. He provides primary care and subspecialty consultative care to adolescents and young adults, including gender affirming care and inclusive sexual and reproductive health and treatment prevention for HIV and other sexually transmitted infections. And next we'll have Teresa Loera. She's a family nurse practitioner and sexual health educator. Teresa has 20 years of professional experience. She's at the largest public health sector in Arizona. She's a native of Arizona and began her career in certified nursing assistant and transitioned into a family nurse practitioner. She's passionate about providing all-inclusive bilingual primary care to all patients, and we're excited for Teresa to give us the lens on family medicine and the integration of PrEP in primary care settings. And lastly, Dr. Joseph Yao is the director of the HIV Laboratory and Hepatitis and is associate professor of the Department of Laboratory Medicine and Pathology at Mayo Clinic. Dr. Yao focuses his research on the development of new and improved clinical diagnostic tests for HIV infection and transplant-associated viruses. The goal of Dr. Yao's work is to provide current state-of-the-art diagnostic tests to improve and optimize the management and outcome of patients with viral hepatitis, HIV infection, and transplant-associated viral infections. And without further ado, I'm going to pass the baton to Errol Fields to launch into the new guidelines from December 2021 for PrEP.
Good afternoon, good morning, everyone. I am trying to share my video, but I'm not able to at the moment. But thank you, Dr. Patel, for the introduction. I'm going to start off today's webinar by reviewing some of the 2021 updates to the PrEP clinical practice guidelines. So here are my disclosures. And so in this brief overview, I'm going to describe the following updates to the guidelines. So patients who should be prescribed PrEP, including the updated flow sheets that have been added to the guidelines for assessing risk indications, as well as clinical eligibility for oral and now injectable PrEP options. the updates to the HIV testing algorithms, and the updates to the laboratory assessments and monitoring for patients on PrEP. So let's start with the changes to risk assessments. These guidelines have really simplified the assessment for individuals at risk for HIV due to exposure from sexual activity as well as from injection drug use. For risk assessments due to sexual activity, the guidelines highlight the importance of starting with an inclusive sexual history, really taken routinely from all patients. And if you can see my pointer here, you can see that there's a suggestion to ask about the gender of sex partners for all patients. The flow sheet on the right also highlights the 3 major risk groups among people who have had anal or vaginal sex in the past 6 months. So first, those with partners living with HIV, particularly those with detectable viral loads, those with inconsistent condom use, and those with a bacterial STI in the past 6 months, including gonorrhea, chlamydia, or syphilis among men who have sex with men, and gonorrhea and syphilis among heterosexually active men and women. An additional indication that is clearly stated in these guidelines is that anyone that requests PrEP should be prescribed PrEP, even if they don't fit into any of these categories based on your sexual history. Anyone that requests PrEP should be prescribed PrEP. For people who inject drugs, this flow sheet has been updated as well. Include risk eligible persons that are those who are sharing injection equipment and have an injection partner living with HIV. And again, anyone that requests a PrEP prescription. So the clinical eligibility and dosing have been updated to some extent as well. For oral PrEP, the clinical eligibility really has not changed. And it still includes a documented negative HIV antigen antibody test result within 1 week before initial PrEP prescription, no signs or symptoms of acute HIV infection, an estimated creatinine clearance of greater than 30 milliliters per minute, and no contraindicated medications. There's now a table 4 that has been added that includes drug interactions to avoid in patients who are considering for PrEP. The guidelines have also included F-TAF or Descovy, which has been added as an oral PrEP option for men and transgender women. And for both FTDF or Truvada and F-TAF, Descovy, providers should prescribe no more than a 3-month supply for each patient. Cabotegravir, the recently approved option for injectable PrEP, has also been added. It has the same clinical eligibility as oral PrEP with the exception of creatinine clearance, which does not need to be assessed since CAB does not impact kidney function. Dosing is described in the blue box to the right, where the initial intramuscular dose is followed by a second dose 4 weeks later, and then injections every 8 weeks thereafter. So these recommendations also indicate now separate algorithms for PrEP naive versus current or recent PrEP users. For PrEP naive, the guidelines recommend an antibody antigen plasma test as the preferred assay, or a rapid blood test as an alternative assay. For those who report HIV exposure, prone event, or signs and symptoms of HIV in the past 4 weeks, a quantitative or qualitative HIV RNA assay is recommended, as shown here on the right side of this figure. For PrEP experienced patients, so that's anyone who has taken oral PrEP or post-exposure prophylaxis in the past 3 months, or received a cabotegravir injection in the past 12 months, the guidelines recommend an HIV antibody antigen assay and now a qualitative or quantitative HIV RNA assay as well. So this is for everyone who's coming in for their PrEP visits. This is now the recommended algorithm for those who are PrEP experienced or have recently been taken PrEP or have received an injection. And we'll certainly talk more about the reasoning for that throughout the rest of the presentation. And then these last 2 slides, you can see the recommended laboratory assessment and monitoring, both for, in this slide you see for oral PrEP, and then the next one will be for CAB. The only change for oral PrEP is a revision of the frequency of assessing creatinine clearance to every 12 months now for those who are less than 50 and had a creatinine clearance of greater than 90 milliliters per minute at their PrEP initiation. And then for all others, the recommendation remains the every 6 month screening for that. The other recommendations around STI testing, hepatitis serologies, and lipids remain the same for oral PrEP. And then for cabotegravir, you can see there's no recommended creatinine clearance testing, and STI testing is also similar, but HIV testing is more frequent, really to align with the every 8-week injections, as you saw before. Really everyone who is prescribed CAB or receiving a CAB injection needs to be tested for HIV to ensure they don't have an HIV infection before each injection. And then, as I mentioned, the ST screening guidelines are fairly similar. So we'll review the reasons behind each of these changes that I've just reviewed in more detail, as well as some practical clinical considerations throughout the presentation by my colleagues, as well as during the question and answer session. And I will turn it back over to Dr. Patel. Thank you.
Thank you. And now we're going to go ahead and transition to Teresa's presentation. Teresa, take it away.
Hi, everyone. Thank you so much for the opportunity to getting to talk to all of you about PrEP in family practice. I've been providing PrEP in family practice now for a little over 2 years now. And initially it was a little intimidating getting to understand the guidelines and which types of tests are recommended. They have recently changed the guidelines as of last December, but the CDC does give us such great and mostly easy to read guidelines for new practitioners who are providing PrEP. Initially, to identify patients for PrEP, the most important thing I believe is just getting a good sexual health history, normalizing sexual health as part of clinical practice, and normalize just speaking about screening and discussion with PrEP for patients who fall under the guidelines. And really that is for everyone who is, any adult who is sexually active should at least get the information about PrEP. As far as the eclipse period, that HIV infection detection, I think what was scary is providing PrEP for somebody who might have already have HIV. That would be a part of your sexual health history intake, and really ruling out if a patient has been recently exposed to acute HIV or having any of those viremic symptoms. That acute HIV syndrome, there's a huge uptake in the viral load, and we're always worried about the increased risk for transmission, and also getting them on PrEP, since that is not HIV medication. Seroconversion does tend to happen at about several weeks into the infection. So any exposure in my practice, I think I've used just kind of my own assessment and talking to the patient and really trying to be the safest you can, as far as, in the last 2 to 4 weeks, have you potentially been exposed to somebody who has HIV or unknown status? Incorporate the 5 Ps in your sexual health history to see if these patients are really safe to take PrEP. The eclipse period that Dr. Patel is sharing here with you guys is that initial acquisition of HIV, and usually right around the acquisition of infection up until 10 days, the time from initial infection until individuals start making antibodies, which is also known as seroconversion. And it does vary from individual to individual. As far as testing, the testing is definitely when you're first getting started with PrEP. Which tests are what? The antibody test, that is usually oral or blood, and it only detects once the patient has the antibodies. There are other types of testing that we do. In our office, we offer the point of care 4th generation antigen antibody tests. And there is also the antigen antibody test that is a blood draw that we usually recommend. And then there is also the HIV RNA NAT testing, which usually detects HIV sooner, I think as soon as like 10 days from exposure. So really discussing these types of labs, how frequently you're going to be doing these labs with patients on PrEP, and getting them really prepared for what is going to be their journey on PrEP, and really reducing their risk for getting HIV. It's amazing that there's medication that could really prevent people from getting HIV. And so, yes, and definitely have your resources. I know there are times when I have to tell patients, just for safety reasons, I'm not sure I can prescribe PrEP right at this moment, but let's get you at least started with your blood work, and then we can move forward with your medication and what we're going to do from there. Back to you, Dr. Patel.
Thank you. Now we're going to transition to Dr. Joseph Yao and his explanation about the technicalities of testing. Thank you, Joseph.
Thanks, Dr. Patel, for your kind introduction. So for the next 5-6 minutes, I'm going to concentrate on describing the testing for HIV before and during pre-exposure prophylaxis and some of the nuances involved in interpreting the results. Here are my conflict of interest disclosures with the 2 diagnostic companies from whom I've received research grant support and serve on their advisory board. Let's take a look at what is the current landscape for qualitative and quantitative HIV NAT testing available for clinicians in the United States in 2020. I've listed the assay brand name in the first column and their corresponding manufacturers, and whether they have FDA approved indications for qualitative and or quantitative measurements. I listed them in alphabetical orders. From Abbott Molecular Inc., there are 2. The Abbott Real Time, which has been on the market for probably 10 years or longer now. It has FDA approved indication for quantitative measurements with the lower limit of quantification down to 40 copies per ml. Recently, newly FDA approved Alinity M from Abbott can quantify down to 20, but neither of these 2 have FDA claim for qualitative detection. There is a pending application from Abbott to have a qualitative detection claim for Alinity M, but that is still forthcoming sometime later this year. And please note that only plasma specimens are accepted for testing at this time for the Abbott assays. Hologic has the Aptima HIV Quant DX assay. It actually has both a qualitative and quantitative claim. And then for the qualitative claim, it actually can accept serum for testing. In fact, the serum specimen actually has a better limit of detection at 9 copies compared to plasma at 12. But this is really not really that clinically significant. But the quantitative assay can report results down to 30 copies per ml. Now, Roche Molecular Systems actually have 3. The oldest of the 3 is the Cobas AmpliPrep Cobas TACMan HIV-1 version 2 assays that only has a quantitative claim at 20 copies per ml. Their newer assay on their new instrument, the Cobas 68-8800 instrument system, can also quantify plasma down to 20, but neither of which have a qualitative claim. They have the newest assay that was approved in late 2020, a qualitative assay that can detect both HIV-1 and HIV-2 RNA, down to 15 or 35 copies respectively. So this actually is quite a sensitive assay and has a qualitative claim to test both serum and plasma, very similar to the hologic Aptima assay. So we have quite a few of these NAT testing, and it's very important for clinicians to communicate with the laboratories that serve their patient population what is or are the assays that are being used in the testing algorithm as part of the diagnosis, and what are the assays used for quantification while monitoring antiretroviral therapy. Now, Dr. Fields have gone through this algorithm with you about the two different type of patient population undergoing PrEP. And I wanted to emphasize that in the algorithm for those who have never received recent antiretroviral prophylaxis, namely those who have not received oral medication in the last 3 months or no injectable cabotegravir in the past 12 months for prophylaxis, the preferred test is a laboratory-based antigen antibody combination with plasma and has the necessary reflex to the antibody HIV-1, HIV-2 antibody supplemental confirmation tests. Now, in certain circumstances where these laboratory-based tests are not available, one could use a finger stick whole blood-based rapid test, but the sensitivity and specificity of these rapid whole blood finger stick tests are not as good as those of the laboratory-based tests. Now, in these boxes here, the non-reactive, indeterminate, or reactive is actually based on a combination of the initial screening test and the reflex confirmation test. So if the confirmation tests show that it's either HIV-1 antibody positive or HIV-2 antibody positive, that actually is a positive result for that individual, and that individual should not receive PrEP. Now, if the result of the reflex serologic test show that it's non-reactive or indeterminate, meaning that it can't tell whether it's antibody 1, HIV-1, or HIV-2, then it's necessary to take a look at the patient's history. Were there any recent risk-prone event in the last 4 months, or whether the patient has signs and symptoms suggestive of acute HIV in the previous 4 weeks. If that is the case, then they should undergo molecular testing. And here, the algorithm recommend either a qualitative or quantitative RNA test for HIV-1. The algorithm also has a cutoff for 200 copies per ml in the case of using quantitative HIV-1 RNA testing. And the reason for using this cutoff is that there are instances of false positive result with these quantitative assays, either because of sample-to-sample contamination during the sample testing process, or the assays sometimes have irreproducible results at the lower end of quantification. So in these individuals that have a low viral load detected, they should actually have a new plasma specimen drawn to be retested before a decision for PrEP is made. Now, for those who actually have no detectable viral load, if it's a quantitative assay or a negative qualitative test, then they can proceed to PrEP if retesting with the blood draw is negative. Now, in the second testing algorithm for those who had taken oral PrEP in the past 3 months or had received injectable cabotegravir in the past 12 months, the recommendation now is actually send plasma, not serum, for both antigen antibody test laboratory as well as a qual or quant RNA tests. So this is NAT testing and serologic testing simultaneously, but not in sequence like what we were doing in the previous testing algorithm or in the normal diagnostic testing algorithm. Here you'll see that there are 4 possible result combinations, and the ones that require further testing are those that have discordant results, meaning negative serologic tests, but positive serologic tests, but negative NAT, or vice versa. And in this case, a new plasma specimen is advised to be drawn for NAT testing, so that if you have 2 net negative results, then that individual is determined to be not infected and could proceed to PrEP, either oral or injectable. Now, what is the reason for having simultaneous serologic and NAT testing in these individuals with recent prophylaxis? And the reason is because injectables and oral PrEP can delay the rise of HIV RNA and antibody tests. So you can see that here on the left-hand side, for those who have not received recent antiretroviral agents for prophylaxis or for treatment, and you can see that the typical profile of high levels of HIV RNA comes first. They start to rise to detectable level by day 11 after a risk exposure. And antibodies usually become detectable from day 21 after exposure. So this is the typical profile of detectability of RNA and antibody during no prophylaxis and no treatment. However, while on prophylaxis or recent prophylaxis, you can see that the rise in the HIV RNA is blunted and delayed, and the antibodies is even further delayed to weeks or months later. And finally, I wish to remind the audience that it's important to be informed about the HIV test algorithm being used in your clinic or institution, and know about the nuances of the NAT testing and serologic tests by the clinical laboratory serving your patient population. Some of the smaller laboratories may not be aware of these new testing algorithm recommended by the CDC in the PrEP guidelines released in the fall of 2021. So it's important to have communications with them so that they know about the various logistics necessary to allow clinicians to order these tests, depending on whether the individuals being considered for PrEP has recently exposed to these drugs or have not been exposed to these drugs. I'll end here and happy to answer questions during the Q&A period. Now I'll pass this back to Dr. Patel.
Thank you, Dr. Yao. So I'm going to build off on the previous speakers. As a reminder, the overview of this webinar today was to introduce you to the audience as primary care providers in primary care settings, the new CDC guidelines that recently changed and added new testing parameters, to kind of go over and synthesize and digest what those testing types are. And now we'll go into key considerations for testing when we think about implementing in our busy primary care centers, as well as cost considerations, et cetera. And I'm going to build off what Dr. Fields, Nurse Loera, and Dr. Yao have said. I'm going to go into, again, I want you to consider this is really geared for individuals in primary care settings, primary care providers. So some of this information lays out basic facts about HIV, and then where you could employ your ID specialist or when to call that CDC hotline. As a housekeeping reminder to the group, please put your question and answers in the Q&A button, not necessarily the chat. And thank you to those who have already put in some questions. We're excited to get to those momentarily. So I just want to transition to just key practical considerations. And this is because this webinar is exciting. We're talking about HIV testing, which is the precursor to the PrEP care continuum, the HIV care continuum, essentially the status neutral care continuum, where you obtain an HIV test and you link that individual to care, whether they're positive or negative, or you start doing what Dr. Yao said, start going down the algorithms if there's an indeterminate, or understanding if there's a false positive. And so the first thing you're going to want to do in your practice, whether large or small, federally qualified health center, family practice clinic, community center in Arizona, like where Teresa practices, you really want to start to build up the clinical protocols, the EHR, electronic health record or electronic medical record order sets. And you're going to want to go ahead and look into billing parameters. So establish that temporary work group. And the reason is today's PrEP is an injectable and oral medications on demand and daily. But tomorrow's PrEP is going to be other modalities. We're going to have options. We're going to have to start being able to implement those options efficiently, communicate with patients, our fellow providers, devise influencers and PrEP champions. So set the stage now. And so as you establish that work group or that lead staff member, or identify that champion for testing and HIV prevention in the context of HIV prevention or HIV testing day, and in the context of PrEP and primary care for today's webinar. After you set that up work group, you're going to want to transition to devising a robust staff education program around testing. And I'm going to waffle between a few slides and this key outline here. You know, honestly, we're going to have to start talking about the HIV infection kind of process, the timing, the window period, as Teresa had talked about, that eclipse or window period. We're going to have to talk about what are the scenarios that you can get HIV during the use of PrEP. And this Lancet HIV graphic, which all of you will get these slides, you can hear the recording, can really process, did I start PrEP during the window period? Was there down the spectrum of time? Was there no use of PrEP and I missed that? And then someone became HIV positive during that time. And was someone HIV positive at baseline and I caught them before they came in? So I think we're going to have to process a few things during our staff provider meeting. And we're going to have to talk about timelines for testing, the testing availability we have, how long we wait for test results, and then where does that PrEP prescription fall in? What tests do I need for PrEP prescribing for this concept of same-day PrEP, which I'll go through? And as Dr. Yao had said, I want to reiterate the third point on here after education. What falls into education is you're going to have to establish your relationship with the center, your lab center, identify are you doing in-house testing, out-of-house testing with perhaps LabCorp, Quest, or other commercial labs? What is that turnaround time? And I want to take a second and talk about turnaround times, just so we know when you call that lab, very practical advice, you're going to ask, my point of care turnaround time, what is that? That's in-house, probably 30 to 60 minutes. When I have my lab-based antigen antibody screening, if I'm sending it to an outside lab, is it around 1 or 2 days? How do I access that lab very quickly? And then when I have to do antibody confirmation testing and differentiation, again, does that fall in that 1 to 2 day period? And then very clearly, when I get that NAT or that RNA test, quantitative or qualitative, what is the time frame that falls into? Is that 24 hours if it's in-house? I want the audience to expect when you're sending that out, it's up to 4 days. And it's important that you know that time, because that is how you're going to process when to follow up on labs, when to connect with your peer navigator and your support staff to possibly check labs, to expect a positive result or a negative result, communicate with your patient or your PrEP user, and very importantly, PrEP messaging with your client. Lay out with your client and the staff on how to communicate with your PrEP users on what is the timeline of getting labs. Don't call me every second. I'm going to call you after 3 to 4 days when that RNA test comes back. And so lastly, in this third point of the slide, you're going to have to discuss some billing codes with the labs. You're going to have to talk about, are the charges reimbursed by insurance? What are out-of-pocket costs? What are the billing code modifiers? And there's two resources that I'm going to lay out soon at the end of this slide set with resources. And I just wanted to highlight some CPT codes. Again, very practical information about costs and CPT codes. What you need to expect as a medical director, a CFO, a COO, a clinic manager, is the cost related to lab testing now as you integrate RNA testing, as you scale up PrEP and have more testing, is that the antigen and antibody testing that's rapid will be around, per CMS guidelines and lab schedule fee, will be around $30. The lab-based HIV antibody test, antigen and antibody immunoassay test, may be around $25. And how does that compare to qualitative and quantitative testing? Well, the rapid antigen and antibody test is around $30, as I said, and the qualitative RNA test may be around $35. The key you need to know is putting that quantitative RNA test in your EHR order set or ordering it will be double the cost, around $85, a little more than double. So to reiterate, the antigen antibody test immunoassays, rapid or non-rapid, lab-based, are around $30 to $25. You start getting into $35 with qualitative RNA testing, and you start going up to around $85 to $90 when you talk about RNA testing that's quantitative and will actually give you the exact viral load copies of HIV if indeed there's HIV infection. Why I bring this up and I didn't put it in print is this is constantly changing. Talk to your lab that you have with. That's very important. And so I just wanted to highlight, when you're devising your protocols, I brought in the two algorithms that both Dr. Fields and Dr. Yo showed. The only thing, if you can see my cursor, I want you to highlight when you discuss with your staff, clinicians and support staff, is really patient communication and provider testing algorithms related to that figure 4A in the CDC guidelines. When you do actually have a PrEP naive, so no antiretroviral exposure, and you have an indeterminate test, and yes, you're sorting that out, and you're going into what is the communication around a possible false negative, what's the communication about an indeterminate, and also simultaneously in parallel, figure 4B in the CDC guidelines. Again, when you've got someone that's antiretroviral load, exposure, what you do when there's a discrepancy, or is a positive and negative, because these are anxiety provoking test results for both the staff, support staff, a peer navigator, a provider, and a PrEP user or an at-risk client. And you really want to have some solidarity and unity around how you communicate that. And this is just to remind you another version of the guidelines that I recommend you cut and paste, print it out, have it electronically, slap it on the board in the provider room and all the, the work rooms, even the patient rooms that you're working out of. And this is just a way to process how to identify through history, clinical eligibility, how to dose and prescribe, and how to follow up. And this is just to remind you in another way about the HIV RNA testing and processing, how that changed, and how to communicate with your staff, both for oral PrEP and now also table 1B in the guidelines with cabotegravir. I wanted to familiarize you all with the figures and the tables that will be high yield for your practice, and introduce you to where the testing is related. And lastly, the timing, as I said, when you're having education, you're doing workflows for your clinic and devising protocols, the timing of that prescription with the test, I want to reiterate, you want to have a rapid HIV test within 5 to 7 days of actually prescribing to know someone was negative at the time of prescription. And you want to have the other labs cooking. That is your lab-based viral load RNA test and your antigen antibody immunoassay that gives you greater specificity and sensitivity to the detection of HIV and closes that window period. However, I want to reiterate, we have busy people taking time off that are running to clinic, paying money for transport. So please don't wait for all your lab results to prescribe that PrEP. It takes a while to do that paperwork and get that prescription in someone's hand. You should consider with implementation same-day prescribing and starts or dispensing. This is a great algorithm in the Lancet HIV in 2020. And lastly, I understand this webinar for everyone can't answer all the questions of indeterminates and patient messaging and communication and messaging with colleagues, creating workflows. So lastly, there are resources to help you around the nation. I want to first start out with the CDC warm lines and hotlines, 9 a.m. to 8 p.m., Monday through Friday. Call them during a break, after a client, on a lunch break. People will answer the phone call and walk you through a case. Next, there's hands-on skills building through DHHS, HRSA, CDC, who has the capacity building assistance networks and the prevention training centers through the Division of STD and HIV. You have the National Association of Community Health Centers, and then you have the National AIDS Education Training Centers. These websites are there. You can contact them through your health department and through your basic CHC networks to have people come to your location and assist you in devising protocols. Then of course there's the IDSA and HIVMA. They have their resources online. And going back to billing, because I know this is a hiccup for many people for implementing, especially the CFOs and the medical directors, and reimbursement and 340B processing. There are special CPT codes and HIV testing information and cost parameters in 2 guidelines with HIVM and also the Illinois Public Health Association. So I wanted to highlight that as well. So without further ado, I'm going to go ahead and stop screen share and turn it over back to Dr. Peeler to go ahead and have some program announcements before we break out to discussion and Q&A.
Thank you very much, Dr. Patel, and thank you to our esteemed panel for the wonderful insightfulness regarding this program, PrEP implementation in primary care, overcoming the barriers to HIV testing. I tell you, we learned a good amount, and I love the resources. Thank you so much. Before we get and open it up to Q&A, and there's still time to put your question into the, click on the Q&A button and put it in there. I'd like to pause and take a moment and make a request. Our programs take obviously a lot of time and preparation. Thank you to our panelists, for instance, to pull this off. We really need your feedback as we try to develop more of these programs under the Dr. John G. Bartlett Memorial Education series. So please, look in the chat, copy the link, and click on that so we can have take a couple minutes of feedback and fine tune what you're looking for as far as content. So now I'd like to turn it over and back over to Q&A with our panelists and Dr. Patel.
Hi, everyone. Thank you for your questions. I'm going to ask Dr. Yao and Dr. Fields to unmute and come on screen. I want to first address a very important question that we got in the chat and the Q&A section is about PrEP in adolescents and HIV testing in adolescents. Dr. Fields, can you go ahead and just comment on some pearls around engaging and communicating and prescribing among adolescents? As you know, this is a very important group for ending the epidemic, and a population that primary care providers will see through family medicine, adolescent, and pediatric care.
Yes, absolutely. Thank you for that question. I did include some comments along with Teresa included some comments as well in the chat. But certainly it's a definitely a high risk group. And I think one of the huge barriers, probably the biggest barrier to PrEP access in adolescents is adolescent and pediatric providers. Not being aware of PrEP, not being comfortable providing PrEP, and not being comfortable assessing risk through sexual exposure and taking inclusive sexual histories. And I think that that's changing, certainly, because we do recognize that it's such a large risk for that population, but because we don't have the information to share with them, they're not getting the information. As a provider of patients living with HIV, I've certainly seen lots of patients who had several missed opportunities in their primary care visits for conversations about PrEP. So I think but the second biggest barrier is going to be around confidentiality and consent. So the majority of the jurisdiction, actually no jurisdiction in the US really explicitly prohibits adolescents under the age of 18 for consenting for PrEP. And there have been several jurisdictions, including mine here in Maryland, who have explicitly passed statutes that allow for adolescents to consent for PrEP use, which is great. The challenge then becomes if an adolescent wants access to that confidentially, there are some breaches to confidentiality that can occur with explanation of benefits through private insurance companies. There's going to be barriers to paying for PrEP for those who are under 18. But there are certainly lots of different resources and strategies and avenues that exist to help those patients get access to PrEP. Such as the Ready Set PrEP program, and PrEPme.org has lots of resources, both for adolescents as well as other vulnerable populations. I think there was a question about undocumented immigrants in the chat, which also can gain access to those programs as well.
Thank you, Dr. Fields. Before I have a question for Dr. Yao, Teresa, you're in a family medicine setting, and you're a nurse practitioner, and you are kind of the PrEP champion in your location. Can you give advice on fellow colleagues who are in primary care settings and family medicine about overcoming the qualms and the intimidation about PrEP as an antiretroviral and kind of these guidelines and having to get, all these different types of tests and sort out the window periods? How do you ease that kind of intimidating factor of some of the stuff we're talking today, so we can really foster scale up in non-HIV specialty centers?
Yes, absolutely. So the biggest thing for me has been just using my resources. As a nurse practitioner, you're never alone. You really kind of have a team of people who are helping you, and just getting rid of the stigma of sexual health conversation in family practice is the first thing. The second part is just learning about it. What we fear, what we don't know. And so really that first part is just getting used to that conversation with your patient. And as I mentioned before, anyone who is usually sexually active is a candidate for at least having a conversation about PrEP. And so I think just know who your resources are. I love that you shared that number through the CDC, and they really kind of give us the guidelines on what to do. And of course, I'm lucky enough that I get to work with a lot of individuals who are HIV and HIV prevention. So we have resources, at least here in the state of Arizona. It feels like I have plenty of resources. And I'm pretty sure if providers just ask, they will also have resources.
So now that we're advocating those hotlines and warm lines to be on speed dial on everyone's cell phones, I want to turn it over to Dr. Yao. Dr. Yao, I wanted to ask you about testing and those gray boxes. Like I said, can you give advice to PrEP champions and clinic managers about how to educate and have training for support staff and providers about that indeterminate? So how to message that indeterminate test to a client, what to do next and that time frame of what to do next.
Sure, yeah. So there are two possible explanations for indeterminate antibody results. So that's in the second step of a three-step testing algorithm. There's third step being the NAT testing, the molecular test. So when you have an indeterminate HIV-1 antibody or HIV-2 antibody or both HIV-1/2 antibody, both are indeterminate. The possible explanations are, one, this is a false reactive screen in the first place, and something in the patient's serum or plasma or even whole blood is cross-reactive with the proteins that are used in the serologic tests. So that's one possible explanation. The other is this could be a incubating acute or recent infection. Recent meaning within contact or got infected within the last 3 weeks. And so it's important to actually wait for the NAT testing result to come back. So in many clinics, these tests are being sent out to labs, reference lab, to perform the qualitative, quantitative tests. So it may take 1 to 3 days, depending on the reference testing lab does it every day or every other day. So in the meantime, while waiting for the NAT testing result to determine whether it's a false reactive screen or whether this is an acute infection, the patient should be counseled that it could be either one. So, the patient knows whether he or she has been engaging in high-risk behavior in the previous 4 weeks. So hard to know without knowing the history. So counseling will have to be based on the patient's anxiety level, risk factors, and sexual activity.
And Dr. Yao, how soon should we call in the PrEP user or the potential PrEP client after that indeterminate test?
Yeah, so I think that I would wait for the NAT testing result first. So the algorithm actually, if you see, that's the 4A for individuals who have never been exposed to antiviral prophylaxis. If the NAT testing is negative, then they should be retested in 2 to 4 weeks. Yeah, so that's the left upper algorithm, and you'll see the bottom green box on the right lower corner.
Yep, I was trying to do a slideshow, but that didn't work. So
Yes, that's all right.
you can at least see where we are now. So
Yeah.
the next step is to get a NAT test as soon as possible.
Yes, or if the patient can't come in, at least no more than 4 weeks from the initial negative NAT test.
Okay, thank you. Well, this concludes our time. Please continue to put your Q&A questions in the Q&A in the chat. We can email you the answers, and please communicate with the host of this webinar to get the recording and the slides, etc. And I'll hand it over to Dr. Peeler.
Hi. Well, thank you again for joining us today. Thank everyone who participated. Thank you, Dr. Patel, for moderating and your contributions. Would like to thank Doctors Field and Yao and Nurse Loria for sharing your experiences. I think everyone, based on the questions and the additional questions I see coming through, looks like we have very good participation. One final note, if you are interested, as Dr. Patel mentioned, in getting a recording of this, it'll take us a couple of days to get this uploaded to the IDSA Foundation website, and we'll be able to get that over to you with the slide deck. Programs like this obviously cannot happen without the generous support of our corporate partners and our industry partners and individual donors that have supported us. So I'd like to take this moment to thank Roche for their generous support of this program, and look forward to seeing you at our next event that's coming up. So have a wonderful day and stay safe. Thank you.